Hi guys, today I'm going to talk about BGA articles, so let's go ahead. So this is the first journal that we're going to talk about is automated closed loop versus manual controlled norepinephrine infusion in patients undergoing intermediate to high risk abdominal surgeries, a randomized controlled trial. So the introduction, a significant association exists between hypertension and adverse postoperative events such as MI, AKI, stroke, or death. Hence, limiting hypertension can reduce the risk of complications after surgery. This randomized controlled trial investigated whether use of CLV could reduce the number of hypertensive episodes during general anesthesia compared with manual norepinephrine adjustments. The CLV controller may help to correct hypertension and reduce hypertensive episodes during anesthesia. So the research question is, in patients undergoing intermediate to high risk abdominal surgeries, will the usage of controlled norepinephrine infusion reduce percentage of case time within hypertension? Inclusion criteria includes adult 18-year patients undergoing intermediate to high-risk abdominal surgeries who require cardiac output monitoring and arterial pressure control to consider for infusion. Inclusion. Exclusion criteria where severe cardiac arrhythmias and severe chronic kidney disease, serum creatinine greater than 2 mg per deciliter, or dialysis. Randomization, blinding, and data collection. Patients were randomized to CLV or manual management. Allocation was concealed and sequentially numbered opaque envelopes. Anesthesia providers were not blinded to group allocation. The subjects and investigator collecting the outcome data were. This is the console diagram of which the eligibility N is 56 with the group having the control. The closed loop vasopressor is 15 with the dark control group around 15. It's randomized around 30 in total. This is called, they usually ask you what is consort, so it's nothing but what's consolidated. It's consolidated standards of reporting trials. The protocol for both the groups includes monitoring. AC standard monitor the cardiac output distance off. Propofol and remifentanil are targeted as targeted control infusions, with maintenance with SIBO and remifentanil infusions maintaining BIS between 40 to 60. Relaxant rock was used for trickling intubation. Boluses were used to maintain TOF less than 2. Mechanically ventilated with tidal volumes of 8 ml per kg, predicted body weight, which includes height and weight, with P5 to 7 centimeters of water. Prevented with spinal morphine. Pain is prevented with spinal morphine before induction. An additional dose was injected IV 1 hour before the end of the procedure, along with paracetamol with or without NSAIDs. Fluid administration is goal-directed to maintain stroke volume variation less than 13% during surgery. And this is the protocol which is computerized. The algorithm goes something like this. So you have an normal concentration 16 mics per ml in a 100 ml syringe pump. A radial arc catheter was inserted and connected via flow track sensor to advanced hemodynamic monitor. So this is the flow track sensor, and this is the radial artery catheter. This was connected to the flow track sensor, and the flow track sensor directly shows us the hemodynamic monitoring. It shows us the stroke volume variation, stroke volume variation, cardiac index. And the system collects the real-time map values from the monitor. The CLV, the closed-loop vasopressor controller, titrates the norepinephrine infusion rate to maintain the predefined map target which we have set. Coming to baseline characteristics, there are no significant differences. CLV and control groups are comparable regarding subject characteristics and potentially confounding factors registered. The outcomes. The primary outcome in this study is percentage of case time with MAP less than 90% of MAP target, is significantly low compared to the control group. The percentage of case time, which is very significant. Percentage of case time target MAP and target is also significant. Percentage of case time with MAP less than 65% is higher in control group compared to the CLV group. Number of episodes with MAP less than 65 or greater than 1 minute is higher in the control group. Longest episode of MAP is seen only in the control group, with the percentage of case time with MAP less than 60 is also seen in control group. The percentage of case time with stroke volume variation less than 13% is seen in CLV group, so that could actually amount to say that there was an episode, and hence the CLV has made sure that this does not happen where the CSSV less than 13%, so it must have increased its dosage, so that could have resulted in these primary and secondary outcomes. Total dose of norepinephrine during surgery is highest in surgery group, which again answers this and this. The mean rate of norepinephrine infusion is also higher in CLB group. The length of stay in ICU is equal in both the groups. The length of stay in hospital is also equal and it's not significant, whereas these three are also not significant per se. The total input, and this is the sum of crystalloid, colloid, and blood product concentration, and total out is the sum of the estimated blood loss, urine output, and gastric suction. The net fluid balance is the difference between total in and total out, which we can see that control group has more net fluid in compared to the CLB group, and it's not very significant. The strength of the study includes this in RCD, with the standardized protocol for both groups, with defined outcome measures and blinding. The weakness is no significant difference in post-operative outcomes. This is a single center with small sample size, which we can see is just 30. Do not recall the percentage of case time of hypertension. It was during induction, as 30% of all hypertension during surgery occurs during anesthesia induction. External validity included patients having intermediate to high-risk abdominal surgeries. And the results cannot be extrapolated to other types of surgery or critical care settings. So the takeaway message is in patients undergoing intermediate high-risk abdominal surgeries, automated closed-loop titration of norepinephrine infusion was associated with significantly fewer hypertensive episodes, a smaller percentage of time with hypertension during surgery, and a greater percentage of time spent within the MAP target range compared with the manual adjustment, but obviously it includes, it also means to say that there is higher amount of norepinephrine being consumed by that group, and the study did not reveal any statistical differences in post-operative outcomes in the two groups.